Okay, our last speaker, we have Dr. Sara Rask. Dr. Sara Rask completed a Bachelor of Science in Life Sciences with distinction at Queen's University in 2001. She obtained her medical doctorate from the University of Western Ontario in 2005 and went on to postgraduate training in internal medicine at McMaster University in 2008 and completed her fellowship in medical oncology in 2010. I want to give her a warm welcome to our stage, so thank you.
Stands between you and lunch, and congratulations for making it this far. Thanks for hanging in. And following on the heels of TACMAC is also a rather daunting task. So I thought what I would try to do is make this quite a clinically based talk, really trying to take what Dr. Mack and all of our important scientists are doing and the work that's going on in tertiary centers, and then kind of pull it local and tell you what are we actually doing in clinical practice, because I think we hear a lot about targeted cancer therapy and personalized cancer therapy, and I thought it might be helpful to hear what actually has made it downstream. So a few disclosures which should not impact on today's talk. So the challenge, of course, is getting, in any area of medicine, getting the right drug to the right patient at the right time. And thankfully in cancer, we actually have a number of tools available and coming down the pipelines which make this much more accessible. The overall goals, I think, for any clinician is to improve outcomes, and that can mean different things depending on the patient. It can be improved quality of life, improved overall survival. Ideally, we want to reduce toxicity, reduce exposure to agents that aren't necessarily going to be helpful for that patient, and certainly in a publicly funded system, we want to ideally use our resources to the best of our ability where they're actually going to count. So in our short time together, and I'm competitive, I'm going to stick to 20 minutes, okay? We will outline the prognostic and predictive biomarkers in personalized cancer treatment, look at the integration of molecular profiling. We hear a lot about this in the news and certainly in research, but what's actually in place? And I'm going to use breast cancer as a model, both because it's my primary site, but also I think it's the most developed in clinically practice. And then very briefly at the end, I'll touch on immunotherapy. So back to our undergrad days, prognostic markers are clinical or biologic characteristics, objectively measurable, and provide information on the likely outcome of a cancer in an untreated individual. So this is the natural history of a cancer if it's untreated. It differs from a predictive marker. A marker can be both, but a predictive marker is a clinical or biological characteristic that provides information on the likely benefit from treatment, either in terms of tumor response or overall survival. So this is a rather concise list of markers that are actually currently in practice and actually expected this day and age for treatment of these disease sites. And so you can see in our common cancers, breast cancer, colon cancer, lung and whatnot, there's already markers available, and those we often even get as early as the biopsy in the case of breast cancer, and already we're starting to cater that treatment plan to the individual. And breast cancer, once again, I think it gives a very easy to conceptualize idea of how we use these markers in practice. The two kind of oldest markers, I would argue, in cancer treatment are the estrogen receptor and progesterone receptor. So these are present on the majority of breast cancers, about 75%. The prognostic aspect comes from the idea that breast cancers that have these markers generally have a much more favorable diagnosis and prognosis than tumors that do not have those receptors. They, too, as I mentioned, tumors can be both prognostic and predictive. They are predictive in that they predict response to endocrine therapy. The third marker, which came on many decades later in breast cancer, but we have been using now for almost 20 years, is the HER2 receptor. So it's present on about 15 to 18% of breast cancers. It is prognostic in that on its own, it predicts a very aggressive cancer, a cancer with a higher risk of recurrence in a woman with this breast cancer, and sadly a higher risk of mortality. But thankfully, predictive. It predicts response to HER2-directed therapies, which has radically altered the natural history of these breast cancers. So Dr. Mack showed us a list of markers and how they're being utilized, but I would argue actually that endocrine treatment is probably the original targeted therapy, and it goes back, I would guess, into at least the 1930s, I think, is when they first described the idea that taking out the ovaries, they knew, actually got a response for women with breast cancer. And they may not have actually understood necessarily the science behind that, but the idea was if you took out the ovaries, the estrogen level fell, therefore less food for these tumors which are estrogen driven. Over the years, we've been able to come up with agents that actually manipulate that estrogen-driven cascade in these breast cancer cells. So tamoxifen, widely used now since the 70s and 80s. It's a selective estrogen receptor modulator, essentially competes with estrogen to bind to the estrogen receptor, therefore kind of stagnating these breast cancer cells. Aromatase inhibitors came onto the market in the early 2000s. In menopausal women, when the ovaries are not functioning any longer, the major source of estrogen is aromatase. And so again, it's a very intelligent way to target these tumors. If you can block that enzyme, lower the estrogen level, you get a response in these tumors. Fulvestrant is less well known. It's widely used now in metastatic breast cancer. It targets yet another area in this cascade, if I can figure this out. And essentially, it actually degrades the estrogen receptor so that even if you've got estrogen floating around, if you get rid of the receptor, it can't act in the cell. HER2-directed therapy, HER2, as Dr. Mack thankfully outlined already, it is a receptor which is upregulated in about 15 to 20% of breast cancers. It is a very strong driver of cell division. So what happens is these two HER2 receptors actually dimerize and send a downstream signal that causes cell growth, differentiation, cell survival, and angiogenesis, and literally fuels these breast cancers and leads to them being very aggressive. This, I would say, is one of the biggest success stories in targeted medicine, in that they were able to devise a targeted antibody, trastuzumab, otherwise known as Herceptin. It goes and binds to that HER2 receptor and essentially stops that cascade. The receptor can't dimerize. The downstream effect is essentially it stalls or kills off the cancer cell. And over the last 15 to 20 years, other agents have come out. So we've come out with pertuzumab, which is another extracellular or outside the cell antibody. It's now used in conjunction with trastuzumab because that's what we do as an oncologist. One drug is good, add another, it's going to be better. TDM1 is genius targeted therapy. It's actually trastuzumab with chemotherapy bound to it. So it makes inherent sense that it will take the chemotherapy literally to the cancer cell. You'll get the highest activity in your cancer cells and ideally reduce activity and toxicity in other cells. There is also a few intracellular targets for this cascade, lapatinib and neratinib. So how successful is this? How important is this idea of targeted medicine? Well, I'm only going to highlight a few stories, and Dr. Mack already showed one excellent slide which showed the radical improvement in survival for women who have HER2 positive breast cancer. This, though, I thought is relevant because it's very recent. It's an update on a trial where women with HER2 positive breast cancer, early stage, so after surgery, are routinely treated with chemotherapy and Herceptin. And to be honest, the biology of this tumor is so aggressive, we will offer chemotherapy to women with tumors, routinely tumors over 6 millimeters. So a woman can come to me and have a 7 millimeter tumor, and I tell her, yes, it's very aggressive, your outcome is going to be excellent, but we have to do chemotherapy and Herceptin. So the idea of this trial was, Herceptin is so good, can we actually downgrade our chemo? Can we put more emphasis on the targeted agent and less on the chemotherapy? And just to highlight here, disease-free survival curves like this do not come frequently in cancer management. So essentially, for those of you in the back end, even up close, this essentially shows the disease-free survival. It is very close and above 95%, and they just published an update at 7 years showing that women, HER2 positive tumors, so remember one of our most aggressive forms of breast cancer, if they got a very light version of chemotherapy and Herceptin, their cure rates at 7 years are still 93%, which is amazing. In the metastatic setting, similarly, awesome improvements in terms of outcomes. So this, again, what do? We add more antibodies Dual HER2 blockade was proven in the Cleopatra trial. This was actually an update of it in 2015, showing that with metastatic disease, traditionally these women sadly would have had a prognosis of less than 2 years because of the aggressive nature of the tumor. With this dual HER2 blockade and chemotherapy initially, we have survivals on average at 4 years. And I would say locally, we have many patients on this who are now well beyond 4 years and still doing very, very well. But it goes beyond just the markers that our traditional pathologists can tell us and our typical clinical markers. So I thought I would just use kind of 2 different tumors here to highlight how limited we still are if we stick to our traditional pathology. So tumor 1, it's a pretty big breast cancer. It's 5.5 centimeters, but low grade. So in general, that means slower, a more favorable prognosis. Lymph nodes were sampled. 1 of the 4 nodes had isolated tumor cells in it, so it's controversial, but that does not bear the same prognosis as node positive, but it's strongly estrogen and progesterone positive. To contrast, a slightly different tumor, so a bit smaller, but higher grade. So you can see that it's difficult to kind of determine how these factors all go together. Still estrogen positive, but progesterone is a bit lower. So 2 patients in clinic, 2 different tumors. Looking at that, who is at the higher risk of recurrence? You actually, I would say, I can't say. 1 tumor is bigger but lower grade, the other tumor is smaller but a bit higher grade. Who's at the higher risk of recurrence? And when I'm speaking with these women, can we safely treat them with just endocrine therapy, just targeted therapy, or is there still a role for chemotherapy? And it goes without saying, based on this kind of model, that it isn't as easy as just kind of saying estrogen positive and estrogen negative, HER2 positive and HER2 negative. You can see that through profiling, they've been able to map out that there's a huge spectrum of breast cancer. And identifying where a woman is or on this spectrum is incredibly important in terms of catering their treatment plan. Just to kind of make that more simple and easy to understand, HER2 positive and triple negative, again, well recognized, those are very aggressive. Where we still struggle in terms of personalizing treatment is the luminal A, luminal B tumors. So these are women who have estrogen positive tumors, plus or minus progesterone positive tumors. Luminal A traditionally is low grade, luminal B higher grade, but a grade 2, you're often at a loss to determine where they fit. So this is where it's important still. We need our traditional pathology. We need our clinical information because, of course, the features of the patient are going to ultimately dictate that treatment plan. But molecular classification is integral now in terms of catering, especially breast cancer treatment, to the patient. In terms of profiling for breast cancer, there are, I would say, 3 commercially available molecular tests now available and funded in Ontario. And just so that we can be very thankful about our tax-paying dollars, to give you an idea, an Oncotype DX test on a breast cancer, which we would do, for instance, on both of these women as they came into clinic, costs just under $5,000, but is fully funded by the government because it's so instrumental in getting the right treatment for the right patient. To highlight Oncotype DX, it was the first on the scene. It's still the most widely used, and I think the easiest to understand. It's 21 genes that essentially, clinically, what do we do? We have our pathologists take a little piece of the tumor. It gets shipped off to a lab in California where they do this test for the world. It's still a patented molecular profile. Again, as you saw, there's a few other profiles available, but this is the most widely used still in Ontario. And they test all of these different genes, recognizing that some of them are associated with higher risk of recurrence, some of them are associated with lower risk of recurrence. Now, to me as a clinician, that doesn't mean very much. If you told me that they have cyclin B1 positive, I'd go, ugh. So thankfully, we get this back. So essentially, it translates that whole complicated spectrum that I showed you into a very understandable graph that is very helpful for me and actually very understandable from a patient perspective. And so essentially, an Oncotype DX will come back with what we call a recurrence score. Those scores range between 0 and 100, and it translates to that subtype spectrum I saw you, especially the luminal A, luminal Bs, where luminal As are at our low end of the spectrum, low is good, and luminal Bs are kind of over at our high risk end of the spectrum. What does this mean clinically? Well, low risk tumors are very indolent, respond very well to hormone therapy, and those women do not get any benefit from chemotherapy. They're going to do very well without it. So I can sit and concretely say to a patient, you don't need chemotherapy, this is great, we can stick with targeted therapy. On the contrary, high-risk tumors, targeted therapy is still not sufficient. These women will still have a high risk of recurrence, and they will benefit from chemotherapy, which isn't chemotherapy. I share Dr. Mack's hope that it will be a thing of the past eventually, but still plays an important role in many treatment plans to date. So if we go back to our first tumor, remember, it was pretty big, but otherwise had good features. We sent it away for the Oncotype, and wouldn't you know, it came back with a low score. That is amazing. So despite having a big tumor, and I must say when I trained just over kind of 10-ish years ago, we would have treated based on tumor size and said, oh, you know, your tumor has good features, but it's big, we're gonna have to do chemotherapy. Whereas now, we've got the access to this test, we get a molecular profile back, very understandable, very readable, it's a low risk score, and we can avoid chemotherapy. That woman is going to have a risk of recurrence of only 8% if she does 5 years of hormone therapy, which is great. I think you can see where this is going. Our second tumor was smaller, but had kind of some intermediate features, grade 2, and PR was a bit lower, and lo and behold, it came back with a very high score. And so had we not done chemotherapy for that patient, she would have still been at about a 22% risk of recurrence, which isn't really acceptable because we know that with chemotherapy we could impact on that. So not necessarily good news for the patient, but she will still have a good outcome. We just needed the access to the test to tell us you do need chemotherapy. It's going to likely improve our odds of cure. I'm just gonna, how am I doing for time? Okay. We'll skip through that then. So briefly, immunotherapy. So Dr. Mack spoke to this morning, which is great, and gave an awesome analogy. Immunotherapy, it's all the rage, to be honest. Patients are asking about it. Clinicians are excited about it. It's in research. It's in the news. And it makes inherent sense to us that our immune system is really important, keeping check on the body, ideally getting rid of infections. And to be honest, our immune system already does some work in terms of watching out for cancer cells and getting rid of them. The problem is that a cancer cell is self, and our immune system is carefully in check to not dissolve self. And so cancers can evade the immune system. And in particular, they are taking advantage of some kind of PD-1 and PD-L1 brakes on the immune system. So they actually will plug into those brakes that Dr. Mack was talking about and shut down the T-cell response. And that's one of the ways that they can get around it. So checkpoint inhibitors, as Dr. Mack outlined, essentially the ones that we've established to date take the brakes off the immune system. And so it's almost like a double negative. It's a brake on the immune system. We put a brake on that, and so therefore the immune system gets revved up. The two inhibitory receptors which are best characterized in this are CTLA4 and PD-1 and PD-L1, but you can see that they have identified many other markers on the T cells, which I anticipate are going to be increasing targets as we move forward. Current immuno-oncology agents, so these are available and funded in certain disease sites. We've got PD-1 inhibitors, PD-L1 inhibitors, and CTLA4 inhibitors, and there are more than 1,000. I think Dr. Mack actually quoted 2,000 clinical trials going on, looking at every different permutation, every disease site, combinations with chemotherapy, surgery, and radiation. Health Canada approved indications to date. This is as of a publication in recently in CMAJ, but as of December 2018. You can see that it's across many disease sites, most established in melanoma, which is known to be a very immunogenic cancer, and so they are very effective there. But now creeping into non-small cell lung cancer, renal cell cancer, head and neck cancer, Merkel cell cancer, hepatocellular, and whatnot. So stay tuned, more will come. But I do think it's important to acknowledge that they haven't been amazingly effective in every study, and there certainly have been some negative trials which don't make it to the mainstream. And so I had a patient ask me yesterday, why wouldn't we just do immunotherapy? It was colorectal cancer, and I had to say, you know, we can't abort standard therapy for something that we really don't quite know what the appropriate use is. The other thing that I just wanted to do a public service announcement is that you can imagine if you take, there's a reason we have brakes on our immune system, and if you take the brakes off of the immune system, you can essentially cause a whole cascade of autoimmune side effects, very different than traditional side effects of chemotherapy, but essentially any system in the body can get an autoimmune effect. The most common we would see would be the gastrointestinal side effects, colitis, skin effects, definitely some eye autoimmune effects, but essentially anything going on. And so it's very important if you have patients who walk into the emergency room or into your primary care office, and every patient will say, I'm on chemotherapy. But you have to delve into that a little bit, because there are so many different agents in use now, from immuno-oncology agents, antibody treatments like Herceptin. Patients will lump that all together, and if we just think about our chemotherapy toxicities, you could easily miss out on diagnosing something important. So please, if ever any questions, there is always an oncologist here locally and in Toronto on call, specifically because of the kind of covert nature of these side effects. So one final plug, smoking cessation is immunotherapy. And it's one thing to look into all these very fancy targets and do all this very expensive research and pay for these very expensive drugs. But there are studies to show that in patients with early stage non-small cell lung cancer, so that would be either treated with surgery for curative intent or chemoradiation with curative intent, smoking cessation improves 5-year overall survival by 37%. So it is still worth telling patients, even after a diagnosis, please stop smoking. Similarly, exercise and diet. We heard about the importance of those things. How does that compare to immuno-oncology? 20 to 25%. So smoking cessation is still more effective in studies than immuno-oncology. And again, it's something completely personal within the power of the patient, would save money overall for the patient and the healthcare system. So in conclusion, there are multiple existing prognostic and predictive biomarkers that already help us to personalize cancer treatment, but of course this list continues to grow and enhance treatment approaches. I do agree with Dr. Mack, though, that this targeted approach is incredibly resource intensive and expensive, and the idea that there's going to be a cure for cancer, impossible. Like, we've only tipped the iceberg in terms of the number of markers out there. And so using things like immunotherapy, which can be more generalizable, I agree with him completely, is probably where we're going to get more bang for our buck and hopefully help more patients in a shorter amount of time. Molecular profiling complements the markers and the clinical pathologic features, and it certainly is creeping into other disease sites as well. So thank you very much.
Thank you, Dr. Rask. So I'll just, we have a question here, Dr. Young.
Hi.
Thanks for your presentation. Very to the point, and you made it on time.
Did I make it in? Okay.
That Oncogene report.
Oncotype, yes.
So I'm at Oncotype. I'm a family physician.
Mm-hmm.
Local family physician. We get reports from you.
Mm-hmm.
I haven't ever seen that pictorial thing. It'd be great.
That's a great idea. So I can immediately start doing that. What I do always do, though, is personally I give the patient a copy. And so that would be another thing, is that they could share it with you. And the pathologists at our center, actually, it's not completely consistent. I think we can improve, but they do often go back and integrate it into the original pathology. But I think getting it to you, I'll explore a mechanism of doing that. It's very easy to understand, and patients will ask about it years later because they want to stop their hormone therapy, and because it isn't awesome. I didn't even go into that today. But they'll be like, what was my risk again, you know? And so I think it would be great to get to you guys. So we'll work on that.
Great, thanks.
Yeah. Yeah.
Just in terms of the Oncotype again, is that becoming standard of care in that it's being done for every patient, or is it only for those patients that are kind of in the middle ground where you're not really sure if they'll benefit from chemotherapy? Because I can assume that if it's a really aggressive cancer, then they'll just say, oh, let's do chemo regardless.
Great question. So just to repeat, where is Oncotype used? And again, sorry, I really had to condense for the 20-minute talk. Oncotype DX is currently studied, validated in women with node-negative, estrogen plus or minus progesterone positive tumors, where you would consider chemotherapy. And so essentially those two were pretty classic cases where we would use it. It is infinitely helpful, though, in telling us about the biology of these breast cancers. There was a study called MAC15 that we participated in, along with many other sites across North America, that is expected to be published, I think they're saying 2021. It looked at women with 1 to 3 lymph nodes positive. Again, these are not to come to the second part of your question, triple negatives, HER2 positives, those require chemotherapy, or at least a discussion of it, so it's not there. It's for your estrogen positive tumors, currently node negative, because node positive we do chemotherapy, but it will, I fully expect, creep into the node positive area. And I actually expect it's going to eventually creep into the neoadjuvant era, where right now if women show up with very large tumors that we need to give them chemo before surgery, it's chemo, whereas many of them may actually have a great response to endocrine therapy and even there. So I expect it to expand in the estrogen positive realm. Only breast cancer, yep. There are similar tests for colorectal cancer and ductal carcinoma in situ, answering slightly different questions, but the concept will creep into many cancers where they actually are able to correlate certain genes in the tumor to outcomes and help us to plan treatment. And so it's just the molecular profile. Oncotype DX is just one example of that molecular profile. Did you want to say anything, Christian?
Prostate as well.
Oh, prostate. Cosmo?
Also starting to be, there's a trial we're going to be rolling to the decision-making for integrating therapy now as well in patients with
Node-positive prostate cancer. Stay tuned.
breast.
Oh, and breast. Oh, yes. Sorry. Yeah. Okay. All right.
Great, thank you so much.
Okay. Thank you.
And so, first of all, what an awesome a lineup of speakers we had today. Just really, really fantastic group. And I know that we've gone over our time, but I know that those in the audience and the many people that are online live streaming will appreciate that. In fact, you can get those talks via the live stream link, and we're probably going to have we'll have that out. It's on my Twitter as well if those want to get that. But it's something you'll be able to get up for a period of time afterwards, and then broken down by speaker as well, which is great. Also, please take the time to complete your evaluation forms. There's a collection box for those completed evaluations at the registration desk, or you can hand them to any one of the members that looks official. And the posters are lined at the wall. Please take the opportunity to do that. And again, thank you so much for those that allowed this to happen, our partners, as well as those that attended and those that are live streaming. Thank you so much again.